So, Professor Albert Singer from Whittington Hospital, University of London.
That's right.
Welcome to Ukraine.
Thank you very much.
That's
nice
your first
to be
time.
Here.
It's an honor for us indeed.
It's the first time I'm in Kiev. Yes, it's nice to be here. Thank you.
We hope that it will not be your last time here, because I think that it could be the beginning of a great friendship.
I would hope so. I have family connections from here. My wife's grandparents come from, as I say, in Australia, just up the road in Lvov.
Okay.
And my parents came from Poland, which is an overnight drive to where they came from.
So a lot in common between
Yes.
us. Okay. Could you tell just a few words about your background? Where did you start your medical way?
I was born in Australia many years ago, 1938, and went into medical school at the age of 17, purely because during the war there were hardly any male teachers. So they said, you look clever, and I have a twin sister, and we were amalgamated. So I came to university at the age of 17, and I never wanted to be a doctor. I wanted to be a diplomat, but I was too young. All my friends were studying medicine. But I came in 1955. It was 10 years after the end of the Second World War. And Australia fought in the war, both in Europe and in the Pacific. And we had many of the prisoners of war who survived the Japanese were allowed 10 years to get their life together and could come into university with just a bare matriculum, no physics, no chemistry. So I came in that year, and the scholarship people at a scholarship said, look, do that for 1 year, and then you can be a diplomat. At the end of 1 year, I'd never done physics and chemistry in my life, but there was a coaching college run by the ugliest woman I'd ever met, and she was brilliant. And she tutored me purely just to pass the exam. So I passed physics and chemistry, and I made so many friends. I said, well, I'll do pre-med, and then I'll become a diplomat. And here I am, you know, at the age of 81, still working and very interested. And then I finished my, my medical school training, and we started to do obstetrics and gynecology and graduated in it. But at the end of my second year in obstetrics and gynecology, I had a cardiac arrest. And that was due to Addison's disease. And it was a miraculous thing, because the external massage had just come out a few months before. They broke my chest, and I aspirated. And the long and the short of it was, well, they said you can't do your clinical work. And in the hospital and university was a man called Professor Malcolm Coppelson, who was a great gynaecologist, but probably the finest colposcopist. He trained in Germany as well, came back to Australia, and he said, look, come in and work in my clinic and see how you go. And he was attached to a brilliant scientist called Bevan Reid, a biologist. And the two of them linked together. They said, you come in the morning, you can go to the clinic with Bevan Reid. I'll take biopsies and specimens. In the afternoon, go to the laboratory. And nowadays, that's what it is. It's interactive. Everything's now interactive. But in those days, I was one of the first to do clinical work. And after 6 months, I was able to resume my training. And so I used to do nights on, bit of operating, but the research as well. In 1968, had a fellowship and came to the States and came to Europe and all the rest of it. And when I was in England, I went to Oxford and loved it, and mentioned it to the professor, and then found 2 years later that he nominated me for a scholarship. So I went to Oxford, and I've been in England ever since. I went for 2 years, and that was nearly 47 years ago. But when I was working with Reid and Coppelson, they said, well, you know, we'd like you to do some clinical work in the research, And Reed said, I'd like to do some other work as well, biological work. The first thing I did, they said, read all the literature. And I said, related to the cervix, that was there. Right? And so I read the literature and I came back to them and I said, what happens to the cervix during pregnancy? Well, it enlarges, gets out. I said, would you mind if I took a cohort of women, 50 women, and followed them every 2 weeks during pregnancy? So that showed me the cervix changes dramatically, etc. And then I took the same women and looked at them 36 hours after delivery, 5 days after delivery, 6 weeks after delivery. So I studied that. And then just took 500 women. I had access to these women because at that time we had colposcopy clinics for screening. Women would come in, have a mammogram, and then they'd have a colposcopy and a Papa Nicolau smear. So I had these women to study. So I looked at what happens to the shape of the cervix from adolescence to menopause, which in a way had not been done. So it was very simple observational studies. Then Reed had done work on metaplasia, when columnar changes to squamous. We knew it occurred on the cervix, and he'd taken biopsies of it at random times, and he found that the metaplastic tissue was phagocytic, and there was sperm found in it. So he has a famous picture in Lancet in 1964 showing the sperm head and that. That developed the theory of exogenous DNA, the sperm, coming into endogenous DNA. So I set about trying to culture them and join them together. Not much happened. And then I said, can I imitate metaplasia? So I got women who were having diathermy to the cervix. And I said, well, that heals up. Can I look at them while they're healing? They said, sure. So I got some of them. I said, you know, if you have intercourse with your husband, it'll make it heal quicker. But you've got to come and see me the next day to see that there's no damage.
After that, you had no choice.
And
you have to proceed.
In those days, there was no ethics at all. And took biopsies, and sure enough, the metaplastic cells for that. We did work then on the animal works, putting some acid down the tubes of the animals and taking off the peritoneal cells, labelling with isotope and see where they came in. So we did a lot of basic work, but probably the most important work I did with them was in relation to the adolescent cervix. This is 1967, 68. We knew that age of first intercourse and sexual partners was important in the etiology, the causation of the disease. And Coppelson got permission from the health minister to screen these girls for syphilis and gonorrhea. There was no chlamydia. People didn't know about chlamydia then. And so we went out to this institution and we asked the girls, can you examine? Of course you can examine us. What we didn't know, what I didn't know, was that these were all girls who'd been abused, and they were put into the home to keep them away from the sexual abuse of the family. And so we looked at the cervix and we saw these bizarre changes. We had no idea what they were, never seen them before. We took biopsies of them and they had these big cells, which I realized were coilocytes. And I went to Professor Koss's, Leo Koss's book, Professor Koss and Danforth, and I saw that the pictures I have on my slides were the same as he has for condyloma. So I wrote a letter to him, and I said, dear Professor Koss, could there be a relationship between what I see as a condyloma and what we have in these bizarre lesions? He wrote back, he said, of course, Dr. Singer, the two are related. And that was 1968, 6 or 7 years before Zahausen wrote anything on this, right? So that was my PhD, and what I did was interview these girls, and they were sexually active, and worked out the age of first intercourse, which was anywhere from about 8 or 9, they were all sexually abused, and worked out what we call the coital age, the age that the cervix had been exposed, and related it to the pathology. And that was my PhD thesis in Sydney. And then I went on to Oxford in 1970.
And you got in love, as you already said.
What I wanted to do was see what happened to these young girls when they got older. The majority of them who were sexually abused landed up in jail, or they landed up in prostitution or something. They were scarred for life, and as we see it now, with all the sexual abuse scandals around the world, these girls are marked for life. They're damaged for life. They can't be anything else. So I managed to get into the Holloway prison in London and convinced the doctor there to give me a colposcopy, a clinic. We had a colposcope, and I took 760 of these girls mainly. The average age was just under 18, and colposcoped them. Found 40% of them had cervical precancer, 5% had cancer. And condyloma were everywhere. And that's where I started.
Very interesting statement that most of these girls got into prostitution or in a jail. What do you think? Maybe it's quite stupid, but what do you think? Is there a direct relation that they were abused and then they got this type of life, or maybe they were abused because of certain features they had before, maybe some social or psychological ones?
I've done a
fair vice versa.
I've done a fair amount of work on sexual abuse, and my colleague who's going to follow me, Peter, will tell you more about it. And I have a wife who works in the children's court. Abuse is very common. Virtually every priest, every bishop has been into it or known about it. It is not uncommon. It occurs everywhere. And in the UK, it's estimated 2 out of every 5 women of some time have come into a form. It doesn't necessarily have to be straight sexual abuse. It can be physical, can be emotional, can be controlling. But these girls have been abused from a very early age. We published a paper, the late Dr. Betty Mansell and myself, looking at women under the age of 25 who had invasive cancer. And the same study has been done a year ago in the University of Melbourne, Australia, by Sue Garland's PhD student, looking at early intercourse. And virtually every one of these women under the age of 25 who has cancer had been abused from an early age. It is, and so many of these girls were abused. When we met them in the home, there was no shame, there was no fear. They loved us because they had been used to a man, putting his attention on them for all these years. So I think many of it stems from the early trauma that they had. And then when they get a bit older, they realize they have trouble forming relationships. And it's a very complex emotional theatre that they find themselves in. And many of them then just give up and go onto the street, become prostitutes, etc., etc.
That's clear, and that's very interesting because when we talk about cervical cancer, we mainly think about HPV, but we often forget about other factors that can influence. And it could be smoking, it could be sexual abuse, it could be different social status, and maybe this trauma, especially in childhood, it also could be related, and maybe it's a target that should be, that's a problem that should be targeted, for example, by work with psychologists, by work with sometimes...
There's an enormous amount of work going on, especially now with the Me Too movement, with the Vatican in the last month. You know, it's come out that virtually every priest in America, every priest in Australia has been involved. You know, there's no shame with it, it's fair. The Australians were the first to have a royal commission into this. It's been going on for 7 years. And people who were responsible for these girls, teachers, football coaches, yesterday, Manchester City has put away £7 million to settle claims against a football coach going back 10, 15 years. Wherever you scratch the surface, it's there. People who have responsibility for these young women abuse them. So part of that, you mentioned the other factors like smoking. My unit was one of the first to show that smoking destroys the immunity in the cervix, the Langerhans of the cells there that eat up the virus, that these cells were influenced by smoking. Yes, the genetics of it you mentioned before, I don't think that's a factor. I think it's more nurture rather than nature, as they say with that. But when I start my lectures, or used to put up a mad cow. It's the first slide. Remember, 10, 15 years. Mad cow disease. And the cows were going like that. And I'd say, there's a mad cow. Next slide would be MAD, mad cow. What is the connection, I'd ask the students. And they'd say, man, it's a male abuse disease. Male abuse disease. It's male. So when Peter Greenhouse was with me as a research fellow many, many years ago, him and his some of the other research fellows, we got looking at the male. And we showed that the male has the same features of HPV on his penis as the girls have in their cervix. And then we looked at the partners of these girls, those who had HPV when we started working on it, and those who did not. And the female partners of them have an increased risk. And in 1941 years ago, I published a hypothesis in the American Journal of ONG called the high-risk male. And I sent to him really with tongue-in-cheek. And I said, I believe there are some men more than others. I'd had, let's say, anecdotal experience, you know, working in a hospital, etc. And saying that certain occupations, the wives of these men, the wives of a fisherman, about 10 times more likely to get cervix cancer than a clergyman in Oxfordshire, or a fisherman out in, when we published this, the first call in the morning was of Grimsby, what are you saying to us about it? But the occupation of a male, like airline pilots, have their wives. If you look at men women who were married to a man who had lost his wife from cervix cancer, their risk was up here. You could say that like likes like. He married someone like his first wife. But there was a lot of evidence already then that this was an infectious disease. And we postulated it was HPV, or called it condyloma. And these were condylomatous changes on the cervix. But it took nearly 20 years until about 1992-93 that people said, probably it is HPV. Yeah.
It was an impressive introduction, I would say, because, you know, this talk could be endless. When you try to be very exact, you always are metaphoric and philosophic. And here is the same, because when you want to solve very practical question like to prevent cervical cancer, you have to start from such difficult questions. But now I would like to be very precise. I would like to talk about diagnostic, treatment, and prevention of cervical cancer. And maybe I would start with a treatment, because it's something very important for Ukraine. Maybe it's not a secret for you that in our countries, in post-Soviet countries, we still continue to treat HPV virus, for example, with immune modulators, with interferons, whatever. What is your attitude towards this way of thinking?
80% of sexually active women at some time in their life will pick up HPV, usually 16, but most women will get rid of it. Many of the women who have this temporary HPV will present with low-grade smears, with low cell smears. HPV is very common. When we treat the cervix, say with an excisional procedure, the HPV sometimes literally goes away. You know, I don't think there are randomized clinical trials to be going. Now that we go into evidence-based medicine, that shows that any of these things, I know when I was in Minsk last year, they showed me an infrared coagulator that does this and that and all the rest of it. There's nothing that I know is therapeutic, except there are trials going on in Boston with a vaccine that's therapeutic against type 16 and 18. But it's still very early days. But the easiest way, if you want to get rid of cervix cancer, there are 3 things you've got to do. And the Australians are boasting that they're going to get rid of it in 10 years. It'll be a rare disease. It's already in Australia, just on the border, been classified as a rare disease. Like Professor Young was saying with Addison's disease, things like that.
Just tell the secret.
Well, the first thing is vaccination.
Okay.
We started vaccinating in the UK about 8 years ago. We vaccinate from the age of 12 with a catch-up to age 18. In Australia, they do it from 10 or 11 up to 26.
Both girls and boys, correct?
Girls, boys, they started about 2 years ago. And the pre-cancer rate is going down like that. And very soon they'll see the cancer rate will be coming down as well.
Vaccination
So,
still,
vaccination.
till what time? Before the first intercourse?
Well, you can start that early. It doesn't seem to matter. And nowadays, there's vaccination until the age of 40. Xavier Bosch from Barcelona is pushing this, what he calls a smart routine, where women from the age of 25, 26 have been vaccinated up to the 40s, right?
Even if they were infected with HPV?
Yeah, it doesn't necessarily, there are now, with Gardasil 9, you have 9 viruses that you, in a way, prevent against. And so vaccination is the first.
Okay.
The second is treatment. Well, the next one is screening, proper screening. And one of my lectures is tomorrow will be on the problem that you have in this country with screening. There's no organized screening, it's opportunistic, and the figures that were shown at the big meeting in Lisbon was about 5 to 8% of Ukrainian women are screened. Now, the screening traditionally for 70 years has been cytology. In the last 10, 15 years, it's HPV. And indeed, in the UK, we're now going to change to HPV screening every 5 years.
Only HPV, no pap smear?
HPV has a positive predictive value of 1 in 6. So for every woman, it's a screening test. It's not a diagnostic test.
Exactly.
So the one person who has CIN or precancer needs to be screened out. And you can then take a smear because the smear has very good specificity. So you can do a smear, or you can do a colposcopy, or you can use some of the biomarkers, methylation, P16 ink, and all these things. So that's screening. It has to be there to screen out. And as I'll show tomorrow, in Eastern European countries, there's just very little screening. Where there is screening, say in Scandinavia, or the UK, the rates have been going down. So screening works. So there's vaccination, screening, and the last one is proper treatment. When you find the disease, you use a colposcope, you can see what you're doing, and very simply use a loop. We use a loop, put local anaesthetic in, takes about 40 to 50 seconds, and the cure rate is high, in the high 90s, 95%. So you need vaccination, screening, and proper treatment. And that they're simple, they're out there,
three
been
elephants
there for many years.
Actually, which stay on the turtle of cancer prevention, and our ground is over. So simple. Why does not it work actually worldwide till now?
Because unless you have a coverage, you take in Kiev, there might be 200,000 women who are eligible from the age of 25 to 60. That's the eligibility. You find unless the screening every 3 years can cover at least 80% of them, even with a poor test, even though the smear test is not great, it may pick up 60 or 70%, but if you do it enough times, it'll work. So you need coverage. What happens in most countries, including America, you get opportunistic. The woman comes in, I got a sore throat. Hop up on the couch and I'll do a smear. Comes in with a bit of irritable bowel. When was your last smear? We do it. So there's no organisation with it. In the UK, it wasn't till 1988 that we were able to force the government, really, and that's a whole story. It could be a whole evening talking about that. We got the government to bring in call and recall. So every 3 years, a woman gets a letter saying, it's time for your smear. She comes along, has a smear, the letter goes out, normal, 94, 95% are normal, right? And the rest are then sent to colposcopy or a HPV test, right? So the screening has to be well organised. And I've got some slides that I'll show that if you introduce screening, within about 5 years, the rate will start going down. So there's been no screening. I've got a slide there that the WHO has that I will show, that the Ukraine has virtually no screening, and even opportunistic isn't great.
Okay, we hope that this meeting would be a real step forward in setting the appropriate and effective screening for our country, and we are sure that it can prevent a lot of cases of cancer in women. And thank you so much for coming. We wait with anticipation for the tomorrow lectures. Thank you, Professor Alberts.
I hope I haven't been too hard on you, but I feel very passionate. The reason I think I was here, we had the big European meeting, the Eurogen meeting in Lisbon, and I opened this discussion on a session called Cervix Cancer in Eastern Europe. And at the end of it, I stood up, went to my microphone, and I looked around. I said, we've had 4 or 5 lectures. There's only one word to describe what we've heard today: catastrophic. Catastrophic. And then someone here heard about it and rang me up and said, will you come? But it was very emotional. You know, the rest of the world, cervix cancer is preventable. It's on the edge of being classed as a rare disease in some countries. And yet, in Eastern Europe, they haven't heard about it. So it'd be a pleasure and an honor to do that.
Yeah, let's be more optimistic and say that a lot of work to do. Let's call it in this way. Thank you so much.
A lot of work.